Good evening, everyone. On behalf of Blisson, I welcome you all for this webinar. And the topic for this webinar is the newer molecule that is carbetocin, which we have launched. And uh, I'm, uh, today we have Dr. Vrunda Doshi Kale Madam as a speaker. So I will take the opportunity to introduce Madam. Dr. Vrunda Doshi ma'am is MS DNB MICOG and professor and head for the Department of Obstetrics and Gynecology at Gajraraja Medical College, Gwalior in MP. Uh, Ma'am is graduate and postgraduate from Jivaji University, Gwalior. She stood first in the university with the distinction in 6 subjects and gold medal in 9. Madam is a teacher, medical teacher for last 26 years, and also she is a member of IAGE since 1994. Dr. Brunda Madam is international has an international fellowship of Indian College of Obstetrics and Gynecology 2006. She is a national Ethicon traveling fellowship Foxy 2002-2003, and Madam is a national young scientist, won the National Young Scientist Award for the North Zone Foxy in 1996. Vrunda Doshi ma'am has 30 national and international publications, and she also played a key role in organizing committees of Gwalior as well as Madhya Pradesh Option Gynae Society, CMEs, and various conferences. So over to you, ma'am. Thank you very much for being a speaker, and the dais is all yours, ma'am.
Mr. Parag, for this generous introduction. And thanks a lot to Bengal Obstetrics and Gynecological Society for listening to me patiently, because I know Bengal has always been the seat of excellence in obstetrics and gynecology, as young undergraduates as well as postgraduate students attending conferences in various cities of Bengal, and all the stalwarts from Bengal. I cannot forget any one of them, how impeccable mark they had in our lives, professional lives, while we were studying. So greetings to all of you from Madhya Pradesh, which is again the heart of India. And I am here to discuss with you. It is not a lecture, but it is rather a recapitulation of what we all have learned in our physiology times when we were young first year students. And we all know that what we learned in those 5 years of undergraduate studies goes along with maybe till our grave, because that is the only knowledge which once or the other ways, by permutation and combinations, which we keep using. So today we are going to discuss about oxytocin, which is the savior for us for obstetricians, and of course carbetocin, which is a new variant of oxytocin. What is the difference between them, and how we are going to utilize this carbetocin to our benefit, as we have done a similar thing with so many other products. Now, coming first to the basic hormone, that is oxytocin. Oxytocin is universally considered as the hormone of love and trust because of its effect in the cerebral cortex and in various areas of the brain, where it affects the social networking and social affection, social attachment system. However, for us obstetricians, oxytocin is the hormone which saves lives. It is the hormone we know it's secreted from the hypothalamus and passes to the posterior pituitary gland, and it has a very rather a twin brother, that is vasopressin, which is also secreted from the paraventricular and supraoptic nuclei of hypothalamus and gets into the posterior pituitary, from where it is secreted. So oxytocin is a centrally produced hormone in the hypothalamus, released to the peripheral circulation through the posterior pituitary gland. It is a nonapeptide, which means it is a protein hormone which contains 9 amino acids in a definite sequence. And this is the molecular structure of oxytocin hormone. We can see it is in a beautiful form, and this 20 carbon chain is very essential for the function of oxytocin. Now, how does this oxytocin work? It Oxytocin displays a variety of biological actions mediated by its molecular target. So on every cell, there is a 7-transmembrane domain G protein coupled oxytocin receptor. So there may be n number of oxytocin receptors, and the oxytocin receptor is expressed in numerous tissues, both peripherally and centrally. So oxytocin has various roles in various parts of the body, but since we are more associated, we are more interested in its effect on the uterus, hence we study more about that. However, oxytocin is not selective for the oxytocin receptor because, as I told you, it has a twin brother, that is vasopressin. So it also acts through the vasopressin receptors, that is vasopressin A1, vasopressin 1A, 1B, and vasopressin 2 receptors. And it also has similar activity as vasopressin. So as a moderately potent agonist of the human vasopressin 2 receptor in the kidney, it can produce antidiuresis, which is the function of vasopressin. It may result into inappropriate water conservation and thus result in hyponatremia in patients who are receiving oxytocin. Even there may be temperature changes and cardiac changes resulting in bradycardia after peripheral administration, as all of us who have used vasopressin in gynec surgeries might have noticed that a small increase in, minimally increase in the vasopressin dose results in severe bradycardia. Same effect may be mimicked by oxytocin in this respect. And if we recollect when we started into obstetrics, we can remember that since there were no different types of oxytocin drugs or were available for augmentation and induction of labor, so patients used to remain on oxytocin drip for days together, and thousands of liters of oxytocin along with fluids were introduced into women in order to induce or augment labor. Cesarean section was also not so common, and these were the patients who suffered from hyponatremia, water conservation, water logging, and sometimes even convulsions which resulted from this. Thanks to the new modalities and new oxytocin drugs, that is not the case now. Now, the beautiful part of about oxytocin is, since it is an amino acid, a peptide hormone, its structure was elucidated by Du Vigneault and his research team in as early as 1950s, and it was the first biologically active peptide prepared synthetically. However, the hormone has a very short half-life. Actually, it lasts for about 3 to 7 minutes only. And in non-pregnant women, though its clearance is about 20 milliliter per minute per kg, and in pregnant women, the pharmacokinetic parameters, they change dramatically because of the increase in the concentration of oxytocinase hormone secreted by the placenta, and which causes proteolysis of oxytocin as a drug. So oxytocin has this disadvantage. One, it cannot be absorbed orally because it is a peptide hormone, and for all similarly sized small peptides, they get rapid proteolysis in the gut by chymotrypsin and other enzymes. So if we take or ingest oxytocin in the tablet form or some other form, it will not get absorbed because it will get proteolized in the gut like any other protein and will be utilized as a form of amino acids, not for its properties. So in circulation, there is oxytocinase. When taken orally, there are proteolytic enzymes. Considering these factors, now we human beings are very innovative, articulative, and try to change things to our benefit since young. So shortly after the oxytocin structure was elucidated in 1953, extensive search started for finding agonist as well as antagonist switch residues and for new analogs with improved pharmacological properties. And from our previous discussion, we know what kind of properties we demanded. We wanted better potency, better selectivity. The analog should not have more effect on the vasopressin type of receptors because they were all disturbing to our cardiovascular systems. It should be potent, rather more potent than oxytocin. Then it should be stable. It should be stable outside the body. It should be having shelf life, long shelf life. It should be not be degraded by heat or similar things. And at the same time, it should have an enhanced bioavailability. So ingested, it should be available to the body in large amounts. And at the same time, it should remain in the body for a long time. So it was a hard task getting all the four things with oxytocin. Given the various uses of oxytocin, which we know, oxytocin and its receptor play a vital role in the initiation and maintenance of labor. No need to describe this. Oxytocin-induced contractility increases as pregnancy approaches term, and there is an increase in the concentration of uterine oxytocin receptors, which occurs during term and even in preterm labor humans, even in abortions. So we know that the smaller is the size of the uterus, the lesser are the number of oxytocin receptors, and so we use larger amount of oxytocin. This was the rule of thumb which was taught to us when we were studying. And now we all know that oxytocin, given its very beautiful and properties of causing uterine contraction, it has been used for labor induction and lactation support, and also for the prevention of PPH since the 1960s. So when the moment when we obstetricians realized that PPH, that is postpartum hemorrhage, can be prevented by paying attention to causing a firm uterine contraction immediately at the time of delivery of the placenta, we can cut the post-placental hemorrhage to a large extent. So various modalities have been used, and WHO has firm recommendations for the use of uterotonics for the prevention of postpartum hemorrhage. Here we go to the recommendations where the WHO says about efficacy and safety of uterotonic for prevention. The recommendation 1 from WHO is use of an effective uterotonic for the prevention of PPH during the third stage of labor is recommended for all births. That is, first thing is all births should be institutional births, which we are following now, and all institutions should be using. Now, what could be the uterotonic agent that can be used? There also a hierarchy has been given: carbetocin, misoprostol, ergometrin, oxytocin and ergometrin fixed combination. Now here I tell you that oxytocin surpasses the list because oxytocin is the one gold standard about which all other oxytocic agents are compared. Now why oxytocin is a common comparator and why it is the current standard of care? Because largest number of trials in the network meta-analysis have been conducted on oxytocin. It is almost 80 years now that oxytocin is in with us. And so we all believe and are relieved by the presence of oxytocin with us. The natural sequence for introducing a new uterotonic option is to evaluate its efficacy with the gold standard option of oxytocin. But now this great important but stands there. Oxytocin has stability and quality issues, particularly in hot countries, that is low and middle income countries like us. Maintenance of quality of oxytocin is problematic as it requires cold storage and transport at 2 to 8 degrees centigrade. Sorry for this big zero, it is actually degrees centigrade. So it is 2 to 8 degrees centigrade. In low resource settings, the cold chain is not commonly available. When I asked one of our doctors here that are they maintaining the oxytocin that is there in the labor room in 2 to 8 degrees centigrade, she said, no, we have not been told about this. And then she only asked the provider, the person, the medical store or whoever was providing her with oxytocin, asked her, are you maintaining the oxytocin which you are providing us at that temperature? That person said, no, there is no need of that. So now we can imagine the oxytocin where it starts or where it gets manufactured and where it is delivered and ultimately where it is used. The cold chain is definitely not maintained for various reasons. Those are IEC reasons, and therefore a heat stable uterotonic agent would be tremendously advantageous as it would not only reduce the cost and logistical problems of storage and transport, but also prevent those atonic PPH deaths where the uterus fails to contract in response to denatured and ineffective oxytocin. I was going through some of the Scandinavian countries' researches regarding oxytocin and carbetocin, and they have given their verdict that even 3 units of oxytocin as a prophylactic agent is enough to give a good uterine contractions. And I was wondered about the issue because in our own department, I see 20 units, 10 units, 20 units, and 40 units of oxytocins we need for causing firm uterine contractions. So maybe the difference lies here that the oxytocin that comes to us that we are using maybe have lost its cold storage continuity in the way. So in order to overcome all those problems associated with oxytocin, the design of oxytocin receptor agonist was done. And in our, it is carbetocin, which was initially developed in 1970s as a veterinary product because as you know that lactation enhancement or lactation induction is an important property of oxytocin. So carbetocin was initially developed as a veterinary product. It is a long-acting synthetic octapeptide analog of oxytocin. If you remember, oxytocin is a nonapeptide which contains 9 amino acids, whereas carbetocin is an octapeptide with agonist properties at the oxytocin receptor only. After intravenous injection, it produces sustained uterine contractions within 2 minutes, lasting for approximately 6 minutes, followed by rhythmic contractions for 60 minutes. So, if a 100 microgram dose of intravenous carbetocin is given, then it will cause sustained uterine contraction in 2 minutes, and the contraction will last for about 60 minutes, that is an hour. That is the golden hour when we want the uterus to remain contracted. When carbetocin is administered by an intramuscular injection, the sustained uterine contractions will last for approximately 11 minutes and rhythmic contractions will last for 120 minutes. However, the onset of action will be a little later, like not within 2 minutes. It will be about 5 minutes to 7 minutes on intramuscular injection. So still there is not a consensus regarding it should be intramuscular or intravenous. However, the carbetocin that is available in India, that is with us, is at present being promoted for intravenous route. How carbetocin has become more useful than oxytocin? It is because there is a structural difference, and what we have to understand is those things which cause destruction of oxytocin by the amino peptidase enzymes, by the oxidoreductase enzymes, and by the disulfidase enzymes that has been changed by replacement of the amino group of cysteine by a hydrogen atom, modification of the disulfide bond by a thioether bond, and substitution of the hydroxyl group of tyrosine by a methyl oxyl group. Now, this is not of much use to us, this knowledge, but yes, it strengthens our uh, uh, belief in the drug because we know that what changes, how the drug has become more useful. Then there is an effort being done for the carbetocin to be made more heat stable. So at 60 degrees centigrade, it may remain for 1 month as well. And at lesser degree centigrades for years, this is what is the effort being done. Now, half-life of carbetocin when it is given intravenously was 42 plus minus 9 minutes. That is up to 8 times longer than that of oxytocin. The terminal half-life of oxytocin is around 5 minutes. So it is quite, it stays in the circulation for a long time. That is a very, very important property of carbetocin. Pharmacokinetic properties of carbetocin allow for its use as a single bolus dose. There is a biphasic elimination pattern after intravenous injection in the prescribed dose range with a terminal elimination half-life of approximately 40 minutes. So it is 8 times more than that of oxytocin, and that is a very important factor so that we don't need to give repeated doses. In oxytocin, we know that after the initial bolus dose, we may need to support the contraction by giving IV infusion for a long time. Again, coming back to the recommendations, the recommendation one, where I read about the various oxytocic agents. The first is oxytocin, and the second WHO recommendation is that of carbetocin. 100 microgram intramuscular or intravenous carbetocin is recommended for the prevention of PPH for all births in contexts where the cost is comparable to other effective uterotonics. So this is where WHO has given a cliché that the cost should be comparable to other effective uterotonics. Of course, because uterotonic is a drug, oxytocin is a drug, which is to be used in the most smallest of the unit, that is even a primary health center, a sub center, even sometimes very close to the households also it needs to be used for the prevention of PPH. So the cost has to be comparable. It can be used for vaginal birth and cesarean section, but since it is given parenterally, skilled health personnel are required to administer it, and so far it is to be advocated only for prevention of PPH. That is important because WHO or any other agency so far has not given a green signal for its use for other indications like induction, augmentation, or rather in cases of treatment of PPH also. So far it has not been mentioned. Okay, so coming to think of it, when we talk about cost, cost is not simply the cost of the drug which we are buying. Cost is the overall cost which we are paying in terms of various things, that is the efforts, the life, the problems that we are facing, and the cases where there may be because of denatured oxytocin there may be PPH. So when we all of us will start using carbetocin, we must think of cost in a holistic term rather than only the cost that is across the counter. Now coming to the comparison between oxytocin and carbetocin, here is a Cochrane network meta-analysis of all uterotonic agents. Here the oxytocin has been compared with carbetocin, and the absolute risk of maternal death with oxytocin was 1 per thousand, with carbetocin it was 2 per thousand, and more or less similar, not much significance in the difference. When the postpartum hemorrhage were more than 1000 ml, again there were comparable results. For blood transfusion, oxytocin yielded 22 per thousand, in carbetocin 18 per thousand, it was 4 fewer. ICU admissions, again very comparable. It is this part where we can concentrate. When the PPH is not much, then of course there is a definite difference between the amount of blood loss. In oxytocin, it is 145. In carbetocin, it is 104. And use of additional uterotonics for the prevention of PPH or for reducing the blood loss was much more with oxytocin, as is our experience, as against carbetocin. So possibly our carbetocin, which is a new molecule, may or it has proven world over to be superior in terms of prevention of PPH, initial blood loss, and not required or not desirable use of further oxytocic drugs, and possibly reducing amount of blood loss. And this is in cases of elective cesarean section, but most of the studies have been done in elective cesarean section. This is one important study where I would like to draw your attention. This is one study where carbetocin versus oxytocin was used to reduce additional uterotonic use at non-elective cesarean section. It was a double-blind randomized trial, and to our surprise, they found that carbetocin and oxytocin had almost similar effects. Now, why so? That is probably because non-elective cesarean sections are those which most often are cases of obstructed labor or patient who is in labor but not progressing, like maybe because of some undiagnosed cephalopelvic disproportion and similar sorts of thing where the patient is already in labor. So we all know that in labor, the oxytocin receptors are very high in number in the uterus, that is the myometrium. And so the oxytocin as a molecule, or oxytocin as a drug, also because of the large number of oxytocin receptors, produces profound uterotonic action. So carbetocin has been found to be most useful in cases of elective cesarean section. Now, this is a very beautiful study conducted in Netherlands as early as 2010. It has been published in 2013, but the study was conducted over a period of up to 12, up to 11. So the study is carbetocin in comparison with oxytocin in several dosing regimens for the prevention of uterine atony after elective cesarean section in Netherlands. So they found that in smaller doses, that is 5 units of oxytocin, which is generally used as a case of for prevention of uterine atony, carbetocin was found much better and superior in causing a prolonged contraction and no need for any further uterotonic agent. With larger doses of oxytocin, I told you that there the oxytocin efficacy is probably very high. So they very often they did not need larger doses. And they said that with larger doses of oxytocin, probably it may be equivalent to the use of carbetocin. However, given only one drug, that is one particular shot, carbetocin was much better than oxytocin here. Now, what about the side effects? That is the immediate question that comes to our mind, that since I also described you that oxytocin through its analog, through its vasopressin receptors causes cardiovascular actions, and therefore all anesthetists are not very happy when we ask them to increase the dose of oxytocin. I always get surprised on the operation table in an elective cesarean section. They're asking the anesthetist, give more oxytocin, give the oxytocin running, because I am here afraid, I am here worried that the patient may not go in PPH, atonicity, because she is an elective cesarean section who was not in labor, so the number of oxytocin receptors are less. But they are all dilly-dally and not ready to give large amount of oxytocin. So now it is probably because they know or they have been told by various authorities that oxytocin has its effect on cardiovascular system because of its vasopressin-like effect. Now here, side effects in the safety population. The side effects that were enumerated are chest pain, flushing, abdominal pain, and vomiting. And they have found that the side effects were not significantly different in both of them. The side effects were more or less same in both the drugs. And then I searched, and it was found in the literature that carbetocin is a functionally selective G protein, that is GQ protein agonist that does not promote oxytocin receptor recycling. So here they have stated that carbetocin is highly selective of the oxytocin receptor, and it has almost no effect on the vasopressin receptors. And that is why, though it causes a very strong contraction of the uterus and a prolonged contraction of the uterus, their effect on the vasopressin receptors are not that prolonged or that strong. And so the resulting cardiovascular complications are also very minimal. So here, this is another study which was conducted, and it has come as latest as in 2018. The adverse effects of carbetocin versus oxytocin in the prevention of PPH after cesarean section. This was again a randomized controlled trial, and the results are worth seeing. Here they have kept a plot. This was maintained by the anesthetist. This was a study done by the anesthetist. So it again is for favorable for us. They have given a picture of systolic blood pressure and diastolic blood pressure immediately after the induction of anesthesia and immediately after giving carbetocin and oxytocin. Now, And you can see that it has remained more or less in the same. So maternal systolic and diastolic blood pressure from start anesthesia until the end of the procedure, we can find they are more or less in the same range. And this is in a colored form, where colored, the red one is oxytocin and black one is carbetocin. So they have categorically said that immediately after you give oxytocin or carbetocin, there is an immediate fall in the blood pressure, but later on it stabilizes and then it remains stable for a long time. Okay. Similarly, in diastolic, in systolic, there is a larger fall, whereas in diastolic, the fall is little lesser and remains the same. Similar is the case of heart rate, that is bradycardia. Immediately after giving, there may be a little bradycardia or reduction in the heart rate, but then it remains so, it does not fall even further with carbetocin. It is comparable in carbetocin as well as oxytocin infusion. Now, there are few studies where carbetocin and oxytocin and misoprostol, they have all been compared. And again, the conclusion is additional uterotonics were needed less frequently by patients treated with carbetocin. And therefore, it appears to be an attractive alternative compared to oxytocin for the prevention of atonic PPH following elective cesarean delivery. This we must mention here. Similarly, carbetocin was studied in cases of twin pregnancies, and the outcome measures need for additional uterotonic drugs was much less with carbetocin as against oxytocin. Again, twins, those who are undergoing elective cesarean sections. Then this is another study where it is carbetocin versus oxytocin plus misoprostol. Means oxytocin plus misoprostol is one group and carbetocin is other group. Here again we find that similar. When two uterotonic drugs are given, still there are additional uterotonic drugs requirement is less in carbetocin. Blood loss is also less and blood transfusion required is less. So carbetocin is found to be superior over combination of oxytocin plus misoprostol, again in cases of elective cesarean sections. So coming to the end of all this discussion and coming back to implementing the updated WHO recommendations, are skilled health personnel who can administer injectable uterotonics available? If no, then using misoprostol tablets. If they are available, oxytocin available. If not available, if oxytocin is of sufficient quantity, not available, then there are various different options, that is ergometrin and even symptometrin have been mentioned. But very importantly is the heat stable carbetocin in context where its cost is comparable to other effective uterotonics, right? And here the last one is use oxytocin 10 units IV or intramuscular. And so for all this discussion was about the comparison of oxytocin and carbetocin regarding their pharmacokinetic properties, the things which we discussed earlier about their potency, about their bioavailability, about their shelf life, and about their efficacy. So what are the practice points here? Oxytocin has persistent quality problems in low and middle income countries as it requires cold storage and transport, and cold chain may not be available. Heat stable carbetocin may be a promising alternative and can overcome the persistent problems with oxytocin quality. Balance of effect favors carbetocin over oxytocin, but yes, the cost, as I told you, needs to be weighed by each and every person in their own settings as to what comprises of the cost. And yes, with any new molecule that is available with us, we become very experimental, and so further research should focus on establishing the most effective route, whether it is intramuscular or intravenous. So that this we are going to do. I am very sure that since carbetocin is now available with us, we will be using it in various ways, and we will be doing researches of all sorts. We have such a big population, so many patients whom we are serving, and so we will get with our own beautiful data regarding carbetocin, various routes of administration, and also the cost effectiveness, and also about the other uses. Focus on implementation of carbetocin for not only prevention, but for other indications such as treatment of PPH. So it would be good for all of us to have the molecule with us and then start using it after our ethical committee gives a green signal for using it in different research purposes, and practically also it can be used now since it has now been uh, available for the use that has been recommended, that is the use of carbetocin 100 microgram in 10 ml of saline or water IV in cases of prevention of PPH, especially in elective cases of cesarean section. It can also be used in vaginal deliveries whenever there is cost efficiency desired. Thank you so much for patient listening. I hope I could do some justice with the topic. Thanks a lot.
Thank you, ma'am, for the excellent presentation, and I'm sure that all the participants must have got a clear idea about the carbetocin and also.
What are the advantages of carbetocin over oxytocin?
Advantages? That is what we have been discussing all the time, that carbetocin is long acting. So if we give one dose of carbetocin, it has been found that we do not need any other oxytocin because its effect lasts for about 60 minutes and it causes a profound uterine contraction. That is one of the reasons it is not recommended for augmentation of labor or even induction of labor, because like methergin, it causes profound contraction, but it acts via the oxytocin receptor. That is the most important thing there, because methergin or ergometrin, they also cause prolonged contraction. Prostadine, that is carboprost, also causes prolonged contraction, but it acts through different pathways which also cause cardiovascular problems. Whereas carbetocin acts through the oxytocin receptor because it is an oxytocin analog. So we have all the advantages of oxytocin, along with the added advantage that oxytocin needs to be given in an infusion form if you want a prolonged action over 1 hour or so, whereas this only single injection will act for an hour or so. So the need for further oxytocin drug is minimized. And the blood loss is also very less. And very importantly, see madam, this I found, because lately I found that even after giving oxytocin, the patients were getting atonic PPHs in our hospital, in our department, in various settings. And I told you that when I questioned where this oxytocin was brought from, what was that, so most of them were not having idea that the oxytocin needs to be preserved at 2 to 8 degrees centigrade. That was one. And while transportation, we cannot monitor how it is getting transported. Once it is there and it is put in the fridge, it will, the temperature will be 2 to 8. But if it has undergone denaturation while on the way, there is no way to detect. So that is probably the reason we need large amounts of oxytocin for producing good contraction.